Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1.
Extract 1, questions 1 to 12. You hear an eye specialist talking to a patient called Jasmine Burton, who has recently undergone eye surgery. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
I've got your notes here, Mrs. Burton, but as we're meeting for the first time, could you begin by telling me a little about your eyesight and the treatment you've had over the years? Did you wear glasses as a child, for example?
Yes, since I was about 7. My parents were concerned by the way I held a book when I was reading, so they took me to an optometrist. He told them I had some kind of astigmatism.
Am I right in assuming that's myopic rather than hyperopic?
Well, yes, I'm nearsighted, if that's what you mean.
That's right. Some people actually have mixed astigmatism. They're far-sighted in one eye and near in the other.
Oh, well, that's not me.
Right.
And as well as my astigmatism, as you probably noticed, my eyes flicker. I'm not aware of it myself, but other people comment on it sometimes. I think you call it nystagmus. It meant that when I had my eye surgery, they preferred to use a general rather than a local anaesthetic.
OK, so did anyone ever tell you what they thought might have caused the condition?
Well, I was once told that my generally poor eyesight is most probably down to the fact that I don't have enough pigment in my eye.
Right.
On the whole, my eyes have never really caused me any significant difficulties, however. I've always had to wear glasses, so that's part of life now. I suppose the only thing is that driving's always been out of the question. I'd never have passed the sight part of the test. That's probably a good thing because it takes me some time to focus, which could make me pretty dangerous if I was ever behind the wheel of a car.
Yes, indeed.
Also, I'm useless at sports like tennis. I think that's because I'm poor at judging the distance between myself and the ball. That was a pain as a teenager, but I've never particularly wanted to play since then. And I've hardly had any issues at work because of my sight. I'm a receptionist in a hotel, and I've never had any difficulty reading computer screens or anything, fortunately.
You've had your eyes regularly checked throughout your life, presumably?
Yeah, that's right, every couple of years. My prescription has changed a little over time, but not that much. Though I certainly couldn't manage without reading glasses these days. About 3 years ago, I was told a cataract was developing in my right eye.
Right.
It was a few years before they decided to remove it. That was this February, and it all went very smoothly.
Good. And you were pleased with the result?
Yeah, I was, thrilled. If only all our failing parts could be replaced so easily. However, when I had the routine checkup a couple of weeks after the operation, I was told there was some clouding. Opacity?
Opacity, yeah.
I think was the word they used. In the capsule containing the new lens. It's a bit disappointing. They could clear it with a laser if it gets to be a real problem, but my flicker makes that rather a risky option. I knew that there's a greater chance of developing a detached retina after a cataract op.
Yes.
But I'm glad to say they found there wasn't any evidence of that in my case.
Oh, good.
All they did was make an appointment for me to be checked out again in 6 months' time. But they said I should get in touch if I felt concerned about my eyes.
And is that what brings you here today?
Yeah, because I am bothered about a couple of things. So firstly, I've noticed more floaters than usual.
Right.
I don't know if that's something to worry about or not. More annoying is the fact that I'm much more troubled by glare than I used to be, so I wanted to ask your opinion on that.
OK, well, let's start by...
Extract 2, questions 13 to 24. You hear a pulmonologist talking to a patient called Robert Miller. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Miller. Now, looking at your notes, I see you've been having a few problems recently. Could you tell me a little about what's been happening in your own words?
Well, yeah, it's a combination of things, really. To kick off, I feel pretty tired most of the time. Just haven't got the energy I used to have.
Right.
And I've got this cough. It's there all the time, and it feels dry. I mean, I'm not coughing up phlegm or blood or anything like that. But the worst thing, which really bothers me, is that I'm so short of breath. Even if I'm just getting dressed in the morning or going up a few steps, I have to stop because I get breathless so quickly. And I've lost quite a bit of weight, too. I mean, I didn't notice at first because it was very gradual, but all in all, I'm about 10 kilos lighter than I was 6 months ago.
Right.
I've not been dieting or anything. I love my food.
Okay. And, well, have you noticed anything else?
Yeah, just take a look at my fingers. The tips look swollen, don't they? And it's the same with my toes, which are bulging out at the end, too. It's weird. And my nails, I don't understand it. They've become soft. They're not hard like they used to be. Look.
Okay. I see what you mean. And tell me a little about yourself. What do you do for a living?
Well, till recently, I worked as a farm laborer. Did it for about 20 years in total. It was hard, physical graft, and it finally got to the stage where I just couldn't cope with it anymore.
Right.
It really took it out of me. So this last couple of years, I've been a security guard, working nights at a local DIY warehouse. It's a bit boring, and the late shifts took a bit of getting used to, but it's okay.
And, are you finding it less physically demanding?
That's right. I just haven't got the stamina now for anything else. In fact, I've even had to give up my golf. Can't manage it anymore. Any spare time now goes on looking after my pigeons. I've done that since I was a teenager.
Oh, very nice. And what about your medical history? Now, I see you were diagnosed with hypertension last year, and you're taking beta blockers at the moment for that.
That's right. My GP said it'd help. Something the GP also said when I saw him about my breathing problems was that he heard what he called crackling noises in my chest.
Okay.
I can't hear them, but he could through the stethoscope.
Okay. And is there any family history of breathing or lung problems or any serious illnesses that you know of?
I don't think so. My mother was always healthy, but my dad developed bad eczema as an adult. I remember the red patches on his hands and face, but he didn't have any lung problems as far as I know.
Right. And, well, looking at your previous tests, you were diagnosed with hypertension about 6 months ago. You had...
An echocardiogram, to check my heart.
Yes.
And a chest x-ray about 4 weeks ago after I saw my GP. That came back okay, as far as I know.
I see.
I'm not keen on hospitals, to be honest. Am I going to need to have lots more tests?
Well, I'm going to suggest you have what's called an arterial blood gas test. This will let us check how well your lungs are working, how they move oxygen into your blood and remove carbon dioxide from it.
Okay.
And I'm also going to order a CT scan. Now, this will be more revealing than the chest x-ray you had. And I may then prescribe a course of corticosteroids. This will depend on what the tests show up. Now, I'd start you on a relatively low dose and then we'll see how...
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a dietitian talking to a patient. Now read the question.
So what seems to be the problem?
I feel such a failure. I'm sure people think that if I just tried harder, I could lose weight. Maybe I need more willpower.
Well, firstly, well done for seeking medical help. Actually, being overweight or obese is a medical problem because being overweight changes how your body
Oh,
works.
thanks, but I do feel that it's my fault for being this way.
Well, I hear what you say, but please understand that these days we consider that obesity is a disease, like high blood pressure or asthma. You see, the body's signals to the brain stop working correctly when you're overweight, and with time you feel less full, even if you eat the same amount. And when you cut calories, your body tries to use less energy to keep your weight the same.
Question 26. You hear members of a hospital committee discussing problems in the X-ray department. Now read the question.
So next on the agenda is the problems in the X-ray department. Nick, would you like to fill us in here?
Well, as you all know, this is a very busy department, so we have 4 X-ray machines in all, including one in the fracture and orthopedic clinic area. But recently, one of the other X-ray machines developed a fault, and so we had to apply for authorization for the purchase of a new tube for it. There's been some kind of hold-up with the paperwork, and while we've been waiting, patients are being brought into the fracture and orthopedic area for X-rays there instead. And of course, that's causing further congestion.
Question 27. You hear a senior nurse giving feedback to a trainee after a training exercise. Now read the question.
OK, that went quite well, didn't it? But it took you a while to work out where the CPR board was kept.
Yeah.
So what does that tell you about this scenario?
We need to check where things are before doing anything else.
Exactly. And of course, it takes a second or two to put the head of the bed down, because you've got to have that part of the bed flat before you slip the board in. I wish there was a quicker way.
So, do I put the CPR board under, or would I normally hand it over to somebody else?
It makes no difference as long as it's done.
Question 28. You hear a trainee nurse asking his senior colleague about the use of anti-embolism socks for a patient. Now read the question.
I noticed that Mrs. Jones isn't wearing the usual anti-embolism socks, but I didn't want to ask her why not because she was asleep. Is it because her legs are swollen?
Well, sometimes we don't recommend the socks if there's severe swelling with edema, but that's not the case here. Mrs. Jones was actually given them initially on admission last night, but she told us this morning that her lower legs were feeling numb. She described it as having no feeling. Until we've checked out the reason for that, for example, it could be an underlying condition which could damage her arterial circulation. We're reducing the risk of thrombosis by pharmacological means.
Oh, I see.
Question 29. You hear a vet talking about her involvement in the management of the practice where she works. Now read the question.
At first, when I took over the financial running of the practice, I felt rather thrown in at the deep end. I really needed to know my stuff and be super organised, especially with the number of new drugs and treatments available now, all of which have to be very carefully costed. It keeps me super busy, but monitoring stocks and so on helps give me confidence and allows me to see how everything fits into the overall picture of working as a vet. My manager's more than happy to leave me to run this side of things. He's in overall charge, of course, but I can always go to him if there's a problem. I keep him closely informed of what's happening. He's always pleased if I manage to make savings anywhere.
Question 30. You hear a physiotherapist giving a presentation about a study she's been involved in. Now read the question.
I'm a physiotherapist, and I'm presenting our poster about constraint-induced movement therapy for children suffering from partial paralysis following brain surgery. We did a case series of 4 children who'd all undergone hemispherectomies. They were admitted to inpatient therapy within 2 weeks post-op and began therapy 2 to 3 weeks post-op. The therapy continued after they were discharged. Our findings were that 3 of the kids regained excellent function and mobility with ambulation and upper extremity function. 1 didn't do so well, unfortunately, but he gave up the therapy early on. This type of movement therapy has been used a lot in adult populations following stroke. The findings here promote moving forward with further research on the pediatric or adolescent population following either hemispherectomy or other surgeries to help us decide how appropriate this therapy would be for them.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
Extract 1. Questions 31 to 36. You hear an interview with a neurosurgeon called Dr. Ian Marsh, who specialises in the treatment of concussion in sport. You now have 90 seconds to read questions 31 to 36.
My guest today is Dr. Ian Marsh, a specialist in the treatment of concussion in sport, and a co-author on a new set of guidelines. So, Dr. Marsh, what's the aim of these new guidelines?
Well, the aim was really to provide a resource, not for the top-level professional sports people, but for parents, teachers and coaches of young people playing sport.
Mm-hmm.
The guidelines basically offer some expert information from a GP, an emergency physician, and myself as a neurosurgeon about what the condition is, also how to identify the symptoms and how to manage it. If any of your listeners have ever had a concussion doing sports, you'll know how frightening it can be. It's confusing and painful and difficult sometimes for teachers, parents or whoever to work out if someone with concussion is okay. I mean, we hope to remedy that.
Mm-hmm. And how do we know when someone is suffering from concussion?
Well, obviously if the person's actually knocked out, it's clear.
Mm-hmm.
But not all patients actually lose consciousness. Often, following a hard knock to the head, they become disorientated or experience headaches, nausea or vomiting. These are signs of concussion, and they may clear initially, but then return when the individual actually undertakes further physical activity.
Right.
When they start to train, say. So it can actually take quite a while for things to really clear up. The essence of it is that people shouldn't start playing again until those warning signs have completely subsided.
Yes, and you say that waiting anything less than 14 days after all the symptoms have cleared would be too early to return.
Yeah, that's right. If they go back too early, they risk a second concussion, and as we know from professional athletes, they may have to give up their sport if they have too many concussions.
Right.
So it's better, particularly in a young person with a developing brain, to allow all of the symptoms to settle and only then return to play. Well, usually return to train first, then return to play after that. It used to be thought that receiving another concussion could lead to severe brain swelling, and that could be fatal, or at least involve a visit to the emergency room. I think the evidence is fairly slim for that. What we do know, though, is that the compounding effect of having one concussion followed by another seems to be more severe than just the one. So it's always better to let the brain recover fully before playing again.
Right, so who's at the highest risk of sports concussion?
Well, actually, a concussion can happen whenever anyone receives a blow to the head. Usually it's a sort of twisting blow, not a straight-on blow. But obviously, people playing sports like rugby, where there's bodily contact, stand more chance of being at the receiving end of such a blow. But having said that, it's just as likely to affect kids kicking a ball around a park as it is to affect top professional players in big matches.
Do you think that youth sports need specialist concussion doctors on hand, like the professionals do?
There's always a risk, and we know that it happens from time to time. But I mean, most games, even the most dangerous ones, are without incident at all. I think people who are involved in running youth sports, whether they be referees, coaches or parents, can be made aware of how to manage concussion, the signs that they need to look out for, and maybe the warnings of something more serious so that they can take the appropriate actions. But I think always having a doctor on the sidelines where young people are playing is just an overreaction.
Right. In the USA, college football is big business. They're trialling helmet sensors and impact sensors. Do you think that's something we need everywhere?
Well, I don't think it'll come to that. I think there are two scenarios here. The first is one where a concussion's a one-off event following a significant blow to the head.
Right.
The second's quite different and involves chronic traumatic encephalopathy. This comes about particularly in American football, where players use their helmets and heads almost like weapons. That type of repeated impact seems to add up over the player's career. That's something we've heard being discussed, mostly in the USA. Naturally, there's interest generally in protecting players, particularly in the professional levels of sport, but I see that as a different matter to the management of concussion itself.
Extract 2. Questions 37 to 42. You hear a presentation by a consultant cardiologist called Dr. Pamela Skelton, who's talking about a research trial called SPRINT, which investigated the effects of setting lower blood pressure targets. You now have 90 seconds to read questions 37 to 42.
Hello, I'm Dr. Pamela Skelton, consultant cardiologist at this hospital, and I'm talking about the recent SPRINT study into the effects of setting lower blood pressure targets, which in turn affects the advice and medication which patients are given. I'm going to describe the patients who were selected, how the trial was conducted, and the implications of its results for us all as health professionals. First, the trial itself. It involved over 9,000 hypertensive participants, aged 50 plus, most of whom were on blood pressure medication. They were randomly assigned to one of two groups, one with a goal of less than 120 millimeters systolic BP, the other with a goal of less than 140 millimeters, the traditional standard. The intention was to follow these patients for 5 years, factoring in the usual dropout rate. As it turned out, however, the trial was stopped after just 3 years, thanks to an all-cause mortality reduction of nearly 30% for the 120 group, which was definitive and shocking, but wonderful. As I mentioned, the participants were over 50s, and it goes without saying that as people age, they develop more diseases and health problems as a matter of course. But there was a specific group of over 75s who did just as well as younger patients. Before the trial, some medics referred to the natural stiffening of the arteries with ageing, suggesting that 120 was too low a target for the over 75s, risking an increase of dizzy spells, which would affect general well-being. But this concern turned out to be unfounded. Others thought there would be a failure to take the number of tablets needed to reach a BP of 120, especially among older participants. Again, this wasn't an issue. The average needed was just 3 per day. The over 75s, already on various drugs, didn't object to extra medication. Participants from this age group who didn't finish the trial were taken out because some conditions, which were already present, worsened. For example, in some cases, obesity levels rose too high. To manage their blood pressure, participants were given standard drugs, Nothing experimental, just drugs that are readily available and low cost. Another key factor was that blood pressure was measured in a very specific way. Rather than give patients an arm cuff for at-home 24-hour ambulatory monitoring, an automated machine was used at the hospital. This took 3 separate readings and averaged them. Also, readings were taken while staff were out of the room to avoid what's called white coat syndrome in patients. Now, some of you may be familiar with the Accord study into blood pressure levels several years ago, which in some respects was similar to Sprint. There are some differences, though. For example, Accord was about half the size of Sprint, and unlike Sprint, the Accord study allowed diabetic patients to take part. Despite this, in general, the Accord participants were rather lower risk than those in the Sprint trial, probably because of the slightly lower average age. The Accord trial didn't show a statistically significant benefit for overall cardiovascular outcomes, but there was a clear 40% reduction in strokes, even though that was a secondary outcome. So, to summarise, the Sprint trial seems to support 120 as a recommended blood pressure target. This is doubtless a landmark study, and, importantly, one which was sponsored by government rather than by the interests of pharmaceutical corporations. I recommend a note of caution, though, as Sprint does contradict previous findings. The Cochrane view, in 2011 for example, said that lowering to under 140 didn't produce a change in the risk of death overall. However, we must bear in mind that Cochrane was looking retrospectively at trials which weren't actually focused on the same particular issue. So it's worth doing a full and systematic evaluation to see where the Sprint trial fits in with what we already know. It's interesting that a few GPs have already been working with older patients to hit lower blood pressure goals, and the new data will doubtless encourage greater take-up of this more interventionist line of attack. But the Sprint results don't mean that everyone with hypertension should be dropping to under 120. Plus, to achieve those lower levels, it's unlikely that lifestyle changes alone would be enough. It could well require several antihypertensive drugs as well. There remain some unanswered questions, of course. For example, whether other groups, like those with a lower heart attack risk, need to keep their blood pressure that low. So, while Sprint can help guide doctors' decisions about some patients, it doesn't mean that a new universal standard for blood pressure is in order. Instead, it's a good reason for everyone to discuss with their doctor their own ideal and particular target.